Esophageal cancer is one of the most lethal cancer worldwide. The overall survival rate is very low. The 5-year survival rate is about 30 to 40% in loco regional disease. And if there is a distant metastasis, the overall survival rate is about 5%. So this makes the esophageal cancer one of the most lethal cancer worldwide. Let's discuss the esophageal cancer now. The esophageal cancer is divided into two types, the squamous cell carcinoma and adenocarcinoma. The squamous cell carcinoma is the most common type. About 90% of the esophageal cancer is squamous cell carcinoma, and the most common location is upper or the mid thoracic region of esophagus. And the risk factor for the squamous cell carcinoma include alcohol, tobacco, and diet. The specific diet can increase the risk of squamous cell carcinoma, such as nitrosamine, betel nut, chronic ingestion of hot food, and beverages such as tea and coffee. This increases the risk of a squamous cell carcinoma. Apart from diet, infection such as human papilloma virus, achalasia, Plummer-Vinson syndrome, and caustic ingestion. By the caustic ingestion, we mean that if a patient have a ingestion of a caustic substance for suicidal purpose or by a mistake, this will increase the risk of squamous cell carcinoma. Apart from the squamous cell carcinoma, the second most common type of esophageal cancer is adenocarcinoma. The adenocarcinoma is more common in Caucasian and male. The overall male to female ratio is 5:1. So it is more common in male and it is more commonly located in distal third of esophagus, mean that it will affect the distal third or the gastroesophageal junction. About 80% of adenocarcinoma will involve the gastroesophageal junction, and the risk factors include GERD and Barrett esophagus. Previously, the squamous cell carcinoma was very common and the adenocarcinoma was very rare. But nowadays, due to the increased risk of GERD, the adenocarcinoma is on rise. So nowadays, there is also a increased cases of adenocarcinoma. After these two type of esophageal cancer, now let's discuss the clinical feature of esophageal cancer, that how a patient will present clinically. Clinically, the patient of esophageal cancer will present with dysphagia and weight loss. The dysphagia will be predominantly to solid, but later on this can develop to a dysphagia to liquid. So initially there will be only dysphagia to solid, but later on there will be a dysphagia to both solid and liquid. Apart from this, there will be a weight loss, anorexia, or dynophagia. Or dynophagia means painful swallowing. Mean there will be a pain during swallowing, and it usually occur whenever there is an extra esophageal involvement. Mean that whenever there is a mediastinal invasion, it will lead to the odynophagia. And rarely the patient can also present with hematemesis, aspiration pneumonia, tracheoesophageal fistula, and chest pain. So all of these are the clinical feature of esophageal cancer. Now come toward the diagnosis, that how we will diagnose a case of esophageal cancer. The most definitive diagnostic test is upper endoscopy with biopsy and brush cytology. It will give the definitive diagnosis and it will confirm the diagnosis in about 95% of our cases. Other than this, we can also perform the transesophageal ultrasound. The transesophageal ultrasound will help to determine the depth of the tumor, and it is the most reliable test for the staging of local cancer. But for the full metastatic workup, we can perform the CT scan of chest and abdomen, chest x-ray, and bone scan. Apart from this, we can also perform a barium swallow, but the barium swallow is useful in evaluation of a dysphagia and a presumptive diagnosis can be made. In short, for the definitive diagnosis, we perform the endoscopy with biopsy. For the local staging, we perform the transesophageal ultrasound. And for the full metastatic workup, we perform the CT scan of chest, abdomen, chest x-ray, and bone scan. So it was all about the diagnosis of the esophageal cancer. Now come toward the staging of the esophageal cancer. We will discuss the esophageal staging here, but remember that this is not the detailed staging of esophagus. It is just an overview of the esophageal cancer. So let's discuss it. The esophageal cancer is divided into four stages: stage 1, stage 2, stage 3, and stage 4. The stage 2 is further divided into 2A and 2B. In the stage 1, the tumor invades the lamina propria or submucosa, but the lymph nodes are negative. In 2A, the tumor invades the muscularis propria and adventitia, but the lymph nodes are negative. In stage 2B cancer, the tumor invades the muscularis propria, mean the invasion is less than the stage 2A, but there will be a positive regional lymph node, mean in 2B there will be an involvement of a regional lymph node. In stage 3, the tumor invades the adventitia. Along with this, there will be a positive regional lymph node, or the tumor invades the adjacent structure. So the stage 3 is defined as that the tumor invade the adventitia. The adventitia is the outer layer of esophagus wall. Means it will invade it, and along with this there will be a involvement of a regional lymph node. Or the stage 3 is also defined as that if the esophageal tumor invade the adjacent organ. So the stage 3 have a two definition, while the stage 4 mean the distant metastasis, mean the esophagus cancer extend beyond its limitation. So these are the four stages of esophageal cancer. After staging, now come toward the treatment of esophageal cancer. The esophageal cancer have very high mortality. The survival rate is very low. The 5-year survival rate is about 30 to 40% for loco regional disease, and if the patient is having a distant metastasis, the 5-year survival rate dropped to a 5%. So to treat the esophageal cancer, the goal of a treatment is palliation, because whenever the patient of esophageal cancer present clinically, it is usually an advanced disease. So the goal is palliation. Palliative procedure which should be performed for esophageal cancer is surgery, mean that we perform the esophagectomy, and it can be curative if the patient disease in stage 0, 1 or 2A stage. Sometimes the chemotherapy plus radiation is used before surgery, and this strategy of using the chemotherapy and radiation before surgery have shown to prolong the survival more than the surgery alone. So it was all about the esophageal cancer.